correct way. The body is looking after itself. And so I guess from a medical point of view, we weren't necessarily very understanding or very sympathetic of how the women might feel. And so very often we didn't do any investigations for pregnancy loss at all. So importantly, pregnancy loss occurs in about 1% of pregnancies in the developed world. It's extremely common. When I talk about pregnancy loss, of course, that encompasses miscarriage, stillbirth, termination of pregnancy due to different abnormalities, but actually perinatal death also fits in here under the definition. So perinatal death very soon after birth, whether that's at full term or earlier in the pregnancy. We know that recurrent miscarriage also happens quite commonly. About 2.5% of women who are actively trying to conceive find that they have more than one pregnancy loss. And again, this is an area where we have had a lot of learning. The definitions have varied between countries, between societies, and over time. We used to say that it had to be 3 or more pregnancies. It used to need to be concurrent pregnancies. So if a woman had had a miscarriage and then a live-born baby and then 2 miscarriages, she didn't fulfill the criteria for recurrent miscarriage. And you might be saying, well, why does that matter? Why do we care about the definition? And the reason is because our societies give us guidelines, and the decision is that you don't necessarily investigate a first pregnancy. So many women would actually go through many pregnancy losses before anybody checked what the underlying reason was. I have had patients who have had 14 miscarriages at varying gestations. Some were early, some were more like 16, 18 weeks, until finally somebody checked their carrier type and or their partner's carrier type and found that they had a chromosome translocation which explained it all along. And they could have actually gone through to IVF for PGT-A years before, and they wouldn't have had to have endured all of those losses. So definitions do matter. Mostly now we accept it's 2 or more. Obviously clinical pregnancies, that means we recognise in the medical world it was a pregnancy, whether that was with a beta HCG or whether there was a fetal heart, and usually before 20 to 24 weeks gestation for recurrent miscarriage. There's lots of reasons you can have recurrent pregnancy loss, chromosome aneuploidy, autoimmune disorders, the uterus having changes, which causes it to be hard to hold a pregnancy. There can be endometrial dysfunction, and there's many other things. Because I'm a genetic counsellor, I'm not going to talk about all of those other things because they're not my expertise at all. It's decided it doesn't want to do any more. Oh, there we go. So it's actually important to try to get to the bottom of pregnancy loss, not only to tell that pregnant person what happened. Most pregnant women feel that it's their fault and they carry a lot of guilt. I've counselled many women where we've gotten to the bottom of things by saying it was a chromosomal change or it was because she was a carrier of a recessive condition. And the relief is incredible because she says, oh, but I thought it was that one time I stayed up too late and I didn't get enough sleep. I thought it was that one time that I took paracetamol. I thought all of these things, and I've been carrying that with me. So I wanted to talk about what can we be looking at in pregnancy loss, because what we've done until now really, if we could obtain products of conception, which is pretty hard, but if you could, we would try to do a carrier type. That's what we always did. But what we found is that between 20 and 65% of the time, we didn't get an answer. Sometimes that was because of contamination. Most of the time it was because of culture failure, because the pregnancy demise had been for too long. And so we were not able to give an answer. But you need an answer because from a medical point of view, you need to be able to talk about, will this happen again and what could I do differently next time? So for instance, if the pregnancy loss has been due to trisomy 21 and it was due to, so not due to a translocation, there still is an increased chance of having a different aneuploidy the next time. You won't necessarily have 2 pregnancies with trisomy 21. I have to tell you I've seen it and they did not carry a translocation, but they're at nearly double or 2 times the risk for other chromosome changes the next time. Most of the time it is a chromosome problem and most of the time it's sporadic. So the chromosome changes account for nearly half of the pregnancy losses. The most common chromosome changes in pregnancy losses occur in about half of the pregnancies. But if you flip it around, 82% of losses are actually due to chromosome abnormalities. So what could you do about it? What have we done that's changed? And some of the things that we've started looking into actually is NIPT, because we haven't talked much about NIPT here, but cell-free DNA, we all carry in our bloodstream cell-free DNA that's being released all of the time. When a person is pregnant, the placenta is releasing that cell-free DNA, and it continues to release that cell-free DNA until the placenta is no longer in the woman's body. So in fact, you can use NIPT and get an answer if you may have no fetal heart, you might actually have a blighted ovum, you might have a uterine cavity. You can tell that there was going to be a pregnancy, but there's no evidence anymore of a pregnancy inside, and NIPT will work in all of those situations. So we've been trying to do NIPT in those situations where a woman has had essentially a miscarriage or a fetal demise. We get results basically every time. Our preference is to use genome-wide NIPT because you very commonly don't find trisomy 21. Actually, what you find is a copy number variant, and so it's better to try to pick that up if you can. And again, why would you do this? Well, it gives an explanation of the loss. It wasn't your fault, it was a chromosome change, it's just random, and we can talk about the future. What else should we do? And it also means in the next pregnancy where you might have a mother saying, well, was it my progesterone levels that were too low? Or, what if I take aspirin? Some of my friends took aspirin and they said that's what kept them pregnant. It means that you're not doing extra interventions that you don't need to be doing. And of course, if you do find that there's an underlying cause that could happen again, you have the option of PGT, or you have the option of doing prenatal diagnosis. So just to remind you, if we look at NIPT for rare chromosomes, when I say rare chromosomes, I mean not trisomy 21, not trisomy 18, not trisomy 13, all of the other chromosomes. And actually, there's been lots and lots of studies on this now using NIPT, and what they find is other chromosome changes or copy number variants happen more often than we expect. And when you find it in the NIPT, nearly 60% of the time you also find it in the fetus. And I don't know about you, but I was taught all of those other chromosome changes don't survive. That's what I learned back in university, and of course that's not actually true. And the other things that are important is if there is a rare chromosome change out in the placenta, you might have a fetus that has standard chromosomes, but having a chromosomally abnormal placenta or even a mosaic placenta is associated with miscarriage, fetal demise. It surprisingly is also linked with congenital abnormalities, ultrasound changes. Even though the fetus doesn't appear to have a chromosome change, it can be fetal growth restriction and spontaneous preterm birth. So if we're looking to try to prevent pregnancy losses, the ones that we can control, things like spontaneous preterm birth and fetal growth restriction, we can work on those to try to ensure a healthy outcome. Very importantly, often these adverse outcomes had no signs on ultrasound whatsoever, and they had no signs when you looked at the biochemistry. And again, we keep coming back to this, don't we, whenever we're talking about pregnancies. Birth defects do only occur in about 3% of pregnancies, but in our line of work it feels like it's most of the pregnancies, right? Because they're the ones we deal with. And so again, we're talking about chromosomal changes, single gene changes, and I'll leave things like prenatal exposure and multifactorial to our obstetric colleagues. So I wanted to tell you about another option that is coming to the fore, and it's genomic autopsy. And for those of you who are involved during the pregnancy, when there's been a loss or a stillbirth, you might raise with the couple that they could have an autopsy of their fetus or their stillbirth if they chose. But it's really complex, and certainly in my day it's very hard right at that moment where they've lost their pregnancy to try to talk about an autopsy. And it's really complex. You need, an invasive look at the body, and many parents just feel they can't consent to that. You might look at the placenta, you might do medical imaging, you might do biochemistry or molecular biology, looking at the family and obstetric history. But it's really important that this is not acceptable to everybody. It's quite confronting, but it's also not acceptable for some religious reasons. And it can be very logistically difficult depending on where you are. If you don't have these services at your hospital, you can't offer these very often. And another thing that we have come across in some religions where the baby needs to be buried the same day, we couldn't, logistically, we didn't have time to get all of those services and get the autopsy done. Particularly where I live in the winter, the sun goes down very early, and the autopsy, the burial must happen by sundown. There just wasn't enough time. So Hamish Scott is a pathologist in Australia, and he joined together with many others doing a research project. And they said, what about if we do a genomic autopsy? Which is an odd concept. We haven't heard that before. We could do it in addition to a normal autopsy, or we could just use this on its own. And what did that mean? So initially they had 200 fetal losses, so stillbirth or fetal death in utero. And what they did initially was whole exome sequencing, because that was the technology that was available to them. And this was a research project, so that was the money that they had. During the course of this testing, they went on to do whole genome sequencing of the fetuses. Where they could, they got samples, of course, from the parents so that they could compare and make it easier. And they found a diagnosis in over half of the cases. So where previously there was just nothing that these families could have, and they didn't look like there was a particular syndrome that had caused the fetal demise, they came up with a diagnosis. What was critically important is that nearly 31% of the cases had an autosomal recessive reason that that loss had occurred. So that means that couple were at risk of it happening again. And again, these were couples who didn't know that, and they hadn't had carrier screening. They found nearly 4% their fetuses had died because of an X-linked recessive condition that would happen again. And they found nearly 8% had an autosomal dominant condition. So one of the parents had this, but had such mild features, nobody had ever picked it up. And it's important for me to say these are excluding de novo. De novo meaning this has happened for the first time in that fetus. So these are all inherited reasons that could happen again. And what this allowed, again, of course for the parents, it was really important. They said, but I didn't do anything wrong, I followed my doctor's orders, I did everything I should, and we were able to say, we understand, you couldn't have changed this outcome. But importantly, it gave accurate counselling. We were able to say, we understand why this happened, we understand the chance of it happening again, and you have some options. And 5% of these couples chose PGT or prenatal diagnosis the next time. So it really mattered to them, and they acted on it. It's important for me to say with this study, this was their very first loss. So it wasn't in a high-risk category. These were babies from all over Australia. This has been so successful and the teams involved feel so strongly about it that we're now looking to have funding to implement this as routine care. So if you have a loss during a pregnancy, even if you have just products of conception, there will be an attempt made to do whole exome or whole genome sequencing. The other thing that's really important that we don't often talk about, but actually it helps us when we're working in medicine, is the genomic testing starts to help us understand the prenatal phenotype. Because very often what we see on ultrasound, we're trying to figure it out, and then you do a test and the result that comes up, you think, that doesn't make sense. That doesn't fit the puzzle at all. It doesn't look like that. But we're starting to learn a lot that what fetuses look like on ultrasound doesn't look the same as when they're born with that same condition. And the other thing that's really important is many of these really serious conditions have absolutely no ultrasound features. So by doing this genomic testing, we're actually able to go backwards, and Dr. Fong talked about that earlier this afternoon. Sometimes going backwards helps us move forward into the future because we can put all of the puzzle pieces together. That was the end there. If there are questions or anything needs further explanation. Okay, thank you.
Kính thưa quý vị, tiến bộ trong lĩnh vực